avoiding radiation therapy is an option for some older patients with breast cancer. Ian.
Thanks very much for the opportunity to present the results of the PRIME2 trial on behalf of the PRIME2 investigators. So this is postoperative radiotherapy in minimum risk elderly, and I have no conflicts of interest. The background to the trial is that postoperative radiotherapy has really remained a standard of care after breast-conserving therapy and endocrine therapy for all patients managed by breast-conserving therapy, receiving endocrine therapy, irrespective of factors such as age. But older patients now represent an increasing proportion of the patients that we see in the clinic, over 50%. They often have a relatively benign natural history, and radiotherapy may represent overtreatment. And in addition, there are competing risks of comorbidities in this age group. And there is relatively sparse level 1 evidence in this older age group. So the aim of the trial was to assess the impact of the emission of postoperative whole breast irradiation in an older, low-risk age group treated by breast-conserving surgery and adjuvant endocrine therapy. So the entry for the criteria for the trial were women who were 65 or older, who'd had breast-conserving surgery for an invasive breast cancer, up to 3 centimeters pathologically in size. They'd had clear margins of at least 1 millimeter. They were estrogen or progesterone receptor positive. They were receiving endocrine therapy, which could be neoadjuvant or postoperative adjuvant therapy. There was no axillary involvement either on sentinel node biopsy or a 4-node sample, and they were medically suitable for all forms of treatment. And the trial had received ethical approval. We excluded women under the age of 65 and those who had a combination of grade 3 histology and lymphovascular invasion, those who'd had in previous in situ or invasive cancer in either breast or previous malignancy in the last 5 years, with the exception of carcinoma in situ of the cervix or non-melanomatous skin cancer. We calculated our sample size, hypothesizing that the risk of local recurrence in the non-irradiated group would be 5%, and it would be 2% in the irradiated group. So we were looking for a difference of 3%. And that required a sample size of 1,300 patients. It's a multi-center study with nearly 100 sites in 6 countries. The median follow-up is now 5 years. We have 7 patients where we have details on local recurrence but are seeking further details. But the data lock was on the 9th of December. So 1,326 patients were randomized to either whole breast irradiation, that's 40 to 50 gray, conventionally fractionated according to local policy, or to no breast radiation and receiving endocrine therapy alone. And in terms of the population, you'll see that the mean age was just over the age of 70, that around 85% of patients were T1, a smaller proportion, 11 to 12%, were T2 up to 3 centimeters. 40% of the patients were grade 1. The majority, 55%, were grade 2. And you can see there are a very small proportion, between 3 and 4%, of patients with grade 3 histology, to some extent reflecting a conservative approach to permissive criteria. The majority of patients did not have lymphovascular invasion, 95% of patients being clear of lymphovascular invasion. In terms of endocrine therapy, all patients received endocrine therapy and 9% given in a neoadjuvant setting. So these are the principal findings. So this is the actuarial local control rate at 5 years. And on the left-hand side, you can see that the cumulative failure rate is represented by a scale of 0 to 10. And you can see that we've got 26 local recurrences in the no irradiated group with a 5-year actuarial rate of 4.1% compared to 1.3% with 6 recurrences in the irradiated group. And the difference is statistically significant with a p-value of 0.02. We've also undertaken an unplanned unpreplanned analysis of local recurrence according to estrogen receptor status. And we've divided these patients into high ER at 7 or 8 or low ER from 2 to 6. And you can see that in the high ER group, the absolute benefits of radiotherapy are relatively small, although there is a reduction of 2.4% from 3.2% to 0.8%, which is statistically significant. And of interest also, in the low ER group, you can see that over 20% of the events occur in the non-irradiated group of the low ER group, 11%, suggesting that this is a group from whom radiotherapy should not be omitted. We've also undertaken a multivariate analysis of factors which might predict local recurrence. So we've looked at T size, margin status, the use of radiotherapy or not, the age of the patients, the grade, the presence of lymphovascular invasion, and ER status. And the only two factors which are statistically significant are the use of radiotherapy with a value of p.001 and estrogen receptor status with a level of p.02. There is no difference in overall survival, 93.8% in the no radiotherapy group and 94.2% in the radiotherapy group. So what can we conclude? I think first we can say that the omission of radiotherapy in women 65 or older with PT1 or T2 up to 3 centimeters in size with negative axillary nodes who are estrogen receptor positive after breast conserving therapy results only in a 4.1% ipsilateral 5-year recurrence rate. And although radiotherapy reduces that recurrence rate significantly, the absolute benefit is very small, 2.4%, in the hormone receptor-rich patients. And excluding radiotherapy doesn't compromise survival. So that the omission of postoperative radiotherapy in hormone-rich older patients receiving endocrine therapy based on the local recurrence rate and the overall survival rate at 5 years appears a reasonable option. Thank you for your attention.
Jan Blom, Netherlands. What is the reason for your, the biological reason for your cutoff age of 65?
I think there's a lot of discussion about what is a continuum. That was the call from the funding body for trials in women 65 or older. You could take a cutoff of 70, but in fact the mean age of the population was 70, which I think is probably be a reasonable average age for the elderly population. But it's a topic that's debated as to what constitutes older patients. I think it is a spectrum, and clearly it varies with physiological ability as well as absolute age.
What proportion of patients do you think would fit these criteria? Is this a very small subgroup that's going to be this low risk?
No, I think this is quite a sizable population of patients. I think I indicated at the start of my presentation that over 50% of patients now presenting with early breast cancer are in the elderly group. Increasing proportions of these are presenting through the breast screening program where the breast tumor is very easy to see. So these represent quite small tumors, and so I think the implications of this study will have broad generalizability to a large and growing number of patients.
Okay, and so can you put that in like any kind? Okay, so if we're just talking about patients 65 and older, would it be like
I think we're probably of those over 65, we're probably talking around 60 to 70% of patients who would fall into this category.
Of low-risk patients that you could potentially, and does that include the hormone status, or does that include the hormone-rich or not?
We've got a relatively small proportion of patients who, with estrogen receptor poor tumours, are only 63 in the study, reflecting the fact that this is a group of patients in which estrogen receptor status is normally high. So those with low ER status tend to be poorly represented in this population, since they tend to have a relatively benign disease and a high representation of ER.
The older you are, the more likely you are to have high ER, so that fits.
Bruce, hold on a second. Kate, go ahead. Okay, Alice.
It's confusing to me. I'm looking at this slide, and there were 19 cases, recurrences with no radiotherapy versus 5 with radiotherapy in the high-risk patients, right? Therefore, if the high-risk patients had radiotherapy, presumably there would be a much lower recurrence.
I think what we're saying is that there are the majority of patients have estrogen-rich tumours where the impact of radiotherapy is relatively modest. What we're saying is that there are a smaller subgroup of estrogen receptor poor high-grade tumours where those are likely to be more aggressive and where radiotherapy is likely to be required. But they represent a relatively small proportion of our population. So we've got a group of patients who have low ER and have had no radiotherapy where the risk of recurrence is relatively high. It is a relatively small proportion of patients, but I think in that group, I think we could say that it would not be safe to omit radiotherapy. I think that the issue about omitting radiotherapy is largely in the high ER category, which represent the majority of the patients within the study.
Bruce, go ahead.
So would you then call radiotherapy in that group overtreatment?
In which particular group?
The group with high estrogen receptor.
I think that's the implication of the study. I think we're really at the cusp of that, because if we say that now the local recurrence rates across a whole group of patients managed by breast-conserving therapy and postoperative radiotherapy are around 2 to 3% now, they've probably come down from about 5% 10 years ago. So the local recurrence rates that we're seeing with the omission of radiotherapy in the low-risk group are of a similar order of magnitude, and therefore I think it's a matter of discussion between the patient and the physician as to whether that very modest benefit is worth the potential risks of complications of radiotherapy and the burden of undergoing treatment.
Will these results change your own practice?
I think it's very likely to change practice within the UK because older patients find radiotherapy very burdensome. The relative benefits are very small. We're not presenting data at this meeting on the results of salvage therapy, so I can't present that data, but there is no compromise in terms of overall survival. So I think it implies that there may be quite a large group of older patients from whom radiotherapy might reasonably be omitted.
Would you comment on other trials that have addressed that? There are.
Well, I think the most relevant one is the CLGB trial, which published in 2004 a 1% difference in local recurrence in the no irradiated group and a 1% risk of recurrence in the irradiated group and 4% in the not irradiated group. And that didn't seem to change practice in the US, and it hasn't changed practice in the UK. But now we're looking at a difference of 2.4% in terms of local recurrence in the group that are strongly estrogen receptor positive. So the benefit, the absolute benefit is smaller, and I think that may well be enough to change practice, but it's up to the clinical community to decide.
Did you see any difference between the estrogen and or progesterone receptor?
we allowed that's not an analysis that we've done, but obviously the majority of patients were estrogen receptor positive, and that the analysis is based on that. There will be a few patients who are ER negative and PGR positive, but I can't comment on that specifically.
Most of these patients would be expected to be PR positive because they have very high ER levels, which tends to correlate with PR positivity.
All right, Dr. Osborne, we're ready for the next speaker then.